For next topic, I invite Dr. Sitesh Roy, sir. This topic is allergy curable immunotherapy, past, present, and future in Indian scenario.
Dr. Sitesh Roy has done his MBBS, MCPS, and MD from USA. He's fellow of American Academy of Pediatrics. He's also a fellowship of American Academy of Allergy, Asthma, and Immunology. He's a super specialist in immunology, allergy, and asthma. He's a founder director of Roy Health Solutions, Multispecialty Clinic, Bandra, Mumbai. Welcome, sir. Sir, can you come?
Thank you very much. It's going to be the final session, and as you can expect, it's a hard-hitting session because everything that we've been discussing in the last 2.5, 3 days ultimately boils down to, can we do something about what we find? So I'm going to take you through the entire gamut, starting from a little bit on the burden, the current options, the evolution of immunotherapy, the currently available immunotherapy, clinical evidence, long-term benefits, and ultimately the guideline recommendations in pediatric allergies, and also a little bit on other immunotherapies other than what we typically think about. So I think this data has been presented already several times, but clearly allergic rhinitis, allergic rhinoconjunctivitis has greatly increased amongst the pediatric population in the last 10 to 20 years. We are now reaching levels where the US was a couple of decades ago, and we will cross them, I'm quite sure, in the near future. And that's literally something that will bring our level of burden for this disease to international levels and more. So once we have a child that we have finally tested, diagnosed with allergies, there are a couple of options, and I've heard all of this from a variety of different doctors, from family physicians to pediatricians to other doctors, and parents coming to us with a lot of different ideas in their mind, but many of them just feel that they can just live with it. Many are told, wait, it will go away. You'll outgrow it. Just wait till you turn 5 or 6, it will go away. And then they're 7, 8, 10, and they're still coming to us with the problem. Let's do something about it. Absolutely. Episodic therapy, it's good, but not ideal. It will give some relief. Long-term watchful management where you do preventive treatment, that's the goal. What you really need is a disease-modifying therapy, something that can actually alter the natural history of a disease. Again, this has probably been presented, but when you treat any allergic disease, there are 4 components. You're talking about patient education, so they know what they have, what they are in for, how long it can go on for, and what they can do about it. Medications, allergen avoidance, and then immunotherapy. Allergen avoidance, I'm sure, has been covered again. Immunotherapy is what we are talking about. So the definition is very simple. It's administering gradually increasing doses of an allergy vaccine. We heard vaccination just a little while ago from Dr. Marathe, to an allergic subject, clinically relevant allergies, that's very important, reaching a dose which is effective in ameliorating the symptoms associated with the subsequent exposure to the causative allergen. The first published data on allergen immunotherapy was about 112 years ago, 1910, Lancet, Freeman and Noon. Sister went out, collected Timothy pollen from the field. Brother got it home, prepared an extract, a very crude extract, and gave the first injection. Within 6 months, they documented that the patient's hay fever allergies in spring were reduced, or in summer. It's a grass pollen. Since then, we've come a very long way in the last 112 years. I always tell people that immunotherapy actually began in India. If you all know Acharya Chanakya and the story of Chandragupta, he had given, and this is just one example, he had given Chandragupta a variety of different poisons, right, from snake venoms to scorpion venoms, because he knew that even orally you could desensitize people from an allergy by giving them increasing doses of it. Some of them almost killed Chandragupta, which we know we have done through immunotherapy. We've had fatalities, so we've gotten a lot better. But immunotherapy didn't begin in the Western world. It began very much in India, which is the cradle of medicine for the whole world, if you look at it. The mechanisms of immunotherapy really begin from the time when we give the very first dose, and the dose is generally a supernormal exposure. So when you have a normal environmental exposure, it's in microgram quantities. probably nanogram quantities. And when you're giving injections, it's in microgram quantities. And that essentially deviates the immune system towards all the Th1 mechanisms, the blocking antibodies, the regulatory T cells, and essentially production of IgG4, which is a blocking antibody. There are defined at least 14 mechanisms by which immunotherapy works. I'm not going to get into those. It's not the primary thing. But even just in the last 10 years, we came to know a new cytokine, IL-35, which has a very important role in modulating the immune system. We knew about IL-10 and TGF-beta for decades now as immunologists, but now we know about this also. This is what was being spoken out in the previous talk, or brought the talk to an end. We know about secondary prevention, where if someone has allergic rhinitis, you don't want them developing allergic asthma, immunotherapy can help. You have one allergen sensitization or two or three, you don't want the fourth and the fifth one to develop new allergen sensitization. So that is your secondary prevention. You have someone who has allergic rhinitis, you don't want them progressing to asthma or asthma with allergic rhinitis. That becomes kind of a tertiary prevention, and you don't want their symptoms to progress. That would be more tertiary prevention. But is primary prevention possible, where you take a high-risk child who either has a sibling or both parents with allergies, you identify that they are already getting sensitized, not allergic yet, and you give them immunotherapy so that you can prevent the development of disease. This is the holy grail of therapy that will come in the future, but it is still a long ways away because this is a very complex topic. And selection of patients is really the hardest point in this. When we look at allergen immunotherapy and what it does compared to pharmacotherapy, it's a loaded scale, as you can see on the left-hand side of the slide, where with drugs, you're largely giving symptomatic care, which works as long as you use the medication. Whereas with immunotherapy, you're looking at long-term changes. You're looking at reduction of symptoms, you're looking at reduction of drugs, you're looking at reduction of exacerbations, you're looking at a long-term efficacy improvement beginning within months of therapy, lasting for years, and even decades after completion of the immunotherapy. I'm going to very briefly go over all these with you in just a second. So we know that the influence of anti-allergic drugs at various points. So while corticosteroids have the maximum benefit, we know that anti-Ig antibodies can actually block the reaction at a very early stage by preventing the mast cell coating by the free-flowing and free-floating IgE. But really, if you can prevent the actual reaction at the very contact, that is where immunotherapy comes in, where the immune system does not see that allergen as a bad guy and is able to tolerate it like a good guy. Allergen avoidance and immunotherapy are the only disease-modifying therapies, according to WHO, when it comes to the management of allergies. These are the various indications where patient preference. So people say it should only be used for moderate to severe disease. I disagree with that. If I have a mild allergic patient who is requiring an antihistamine on a nasal steroid, and the parent does not want the child to stay on medications all the time or frequently, they absolutely deserve to be on immunotherapy. And I think the guidelines also agree with that. And there are very clear indications besides allergic rhinoconjunctivitis, but also stable asthma, also atopic dermatitis in well-selected patients can make a huge difference. House dust mite immunotherapy has literally cured a lot of patients of mine. And then with Hymenoptera venom, which you heard an excellent lecture yesterday by Dr. Narmada, the efficacy can go up to 95 or 99%. So what are the indications we are looking at? Allergic rhinitis, conjunctivitis, the top data and the top level of evidence. Allergic asthma, very good evidence. Large local reactions to insect, that's mostly for adults, not for pediatrics. In pediatrics, only systemic reactions are relevant. Atopic dermatitis. Sensitization should be relevant with the right kind of symptoms. So it can't just be, so I know a lot of labs these days which will send a person to a doctor's clinic and say, don't worry about whether you can diagnose allergies. We'll do the test and we'll give the immunotherapy. There is no contact with the physician of the patient to know whether the skin test has any clinical correlation with the symptoms of the patient. So it's a very, very scary situation going out there. Symptoms should be of sufficient severity and duration, and the availability of high quality antigens. That is really something we are struggling with, but we make do with the best we have and work on it. So this is kind of for rhinitis asthma, right from the moderate to severe intermittent allergic rhinitis, okay, to the mild persistent, the moderate persistent. And then in the same way with asthma, with well-controlled and partially controlled, Ig-mediated allergies being a trigger, you can do immunotherapy. So only the mild intermittent allergic rhinitis and the uncontrolled asthma patients are the two categories where immunotherapy can be done only once you bring the asthma under control. The mild intermittent obviously don't need it. When you compare allergen immunotherapy combined with drug therapy versus drug therapy alone, there is a significant reduction in terms of the medication score and the symptom score that can be seen in patients. And I think this has been proven beyond doubt. This is actually a review paper, but there are multiple papers like this. There are two forms, subcutaneous, sublingual. We won't get into too much details about it, but I'll speak about it. The typical allergens that you're looking at, and these are the same ones that are available worldwide. So the strongest and most solid data that we have for success with allergen immunotherapy, with rates going above 80%, happen for house dust mites and for pollen, variety of pollen. Animal dander comes in at a 2+, as you can see here. Molds come in at a 2+, and cockroach comes in at a 1+. Okay, depending on whose hands it is in, why it is being done, how it is being done, I guess it can be a 2+ also. What are the contraindications for immunotherapy in pediatrics? So there are some absolute contraindications. If the FEV1 is less than 70%, you don't want to do immunotherapy, you want to treat the asthma and bring the FEV1 higher. Have I done it in people lower than that? I have, but then again, I have that much experience to know when I can do it and I cannot. Age less than 2 years, not recommended. Serious immunological disorders, you can read the rest of it. Intake of beta blockers, uncommon in children, but is in the list. Relative contraindications, age less than 5 years, severe atopic eczema, cardiovascular diseases. The youngest child that I have done immunotherapy with was 18 months old and had serious life-threatening fire ant allergy, okay, to the point that she had been in the ICU on a ventilator both times that she was bitten. And the parents were very clear that they did not want to take a risk for the child to get bitten again anytime in the future. And with a very, very serious, long 4-page consent, we began the immunotherapy. The child by the 4th dose was very happily taking the injections without a single squeal or a cry. And by age 1, by 1 year of completion of the immunotherapy, that child was bitten by 25 fire ants and had nothing more than a little swelling at the site of injection and a few sterile pustules, which are expected to happen. So these are all, as I say, in the context of a large scenario. Allergen-specific immunotherapy for pediatric asthma and rhinosinusitis, the evidence is very strongly supportive that it helps. I'll present more data. There is improved efficacy. I'll go through each of these. So when you look at symptom control, you can see with subcutaneous immunotherapy done in the total symptom score and the total nasal symptom score, in both cases, the significant improvement compared to the common drugs. From the very first grass pollen season in this study, improvement was seen, which is generally 3 to 6 months within the starting of treatment. And in every aspect of therapy, improvement is seen. This improvement is sustained for up to 10 years after completion of immunotherapy. So there is plenty of data starting from the very first published paper in 1967 by Johnston et al., who showed that you can see improvement for up to 7 years after completion of 3 years of immunotherapy in a child. So when we talk about getting as close to curing a disease, this may be as close as we can get. Are there relapses? Yes, there can be relapses in up to 30% people. There can be with new allergens that were not desensitized before, and desensitizing them can make all the difference in the world for them also. This is another data. Again, this is the data from 2007 by Jacobson, where they showed that specific immunotherapy at a 10-year follow-up had a 45% reduction in the chance of developing asthma at 3, 5, and 10 years. That's pretty big. New sensitizations reduced by half in kids who underwent immunotherapy. This is with the allergoids, which we had in India till about 2.5 years ago. Now we don't have the hypoallergenic house dust mite extract, but this was shown to substantially reduce the rate of asthma and reduce the rate of new sensitization even 12 years after completion of the subcutaneous immunotherapy. Reduction of inhaled corticosteroids by a significant amount, 63% reduction in inhaled corticosteroids. That's a very big change when you look at a disease that may require therapy for decades if you are not doing something to change the disease. And this is a very important slide because, again, it's a very tricky topic to say, can you cure allergies? I believe I'm an practicing allergist immunologist for now 22 years. And I can tell you, you can cure specific allergens. You can't cure the innate tendency of the human being to develop atopy. Okay. To change the innate nature of the human being to develop atopy, you have to go into their diet, their lifestyle, their stress levels, and a lot of other what I call holistic medicine, which I do in my practice. And you really have to change the nature or the body type of the human being, which is not an easy process and certainly not something that modern medicine easily buys into. But if 60% children could come off their inhaler at the end of a 3-year of allergen immunotherapy, that's a pretty drastic reduction, I would say, for a disease like allergic or pediatric allergic asthma. And that's about as close as we can think of getting with this disease. I believe I was given 30 minutes, so I'm going to continue a little bit longer, okay? The risk factors for allergen immunotherapy, current allergy symptoms and potential allergen exposure, current infection. So if someone is actually infected, we don't start immunotherapy for them. I have delayed this several times. Patients have come in. We've told them if you're unwell, we are not going to start it right away. They still come in thinking we'll begin, but we have to keep them in a healthy state before we give the vaccine. Mast cell disease, because you can get a lot of systemic cutaneous reactions in such cases. Previous systemic reactions to skit or slit, uncontrolled or severe asthma, excess dose escalation, high degree of sensitization, especially with venom and with grass pollen. Systemic reactions and anaphylaxis are known, and they are well described. These are the two classes of allergens you really have to be very careful while desensitizing, especially with the subcutaneous immunotherapy. Beta blockers, poor injection technique, overdose, there are errors. So the staff who's giving the injection needs to be extremely well trained unless you as the physician are controlling every single dose and making sure it's right. Lack of adherence, and then high intensity physical exercise, because in some patients doing a lot of exercise after the dose can actually enhance the possibility of a massive mast cell degranulation leading to an allergic reaction. Fatalities just in the US, when we look at data in the last big review that was done between 2007 to 2011, there were no deaths that were reported. This is a very positive thing. We have excellent parameters. They are available online for free, and following them and having always all the emergency medications, your antihistamines, your steroids, your adrenaline, oxygen, potentially even further drugs, H2 blockers, glucagon, you name the list. It's a good idea if you're doing subcutaneous immunotherapy that you should have all this accessible and regularly reviewed in your clinic to prevent this problem. So what do the practice parameters and the guidelines say? Immunotherapy for children is effective and well tolerated. It is shown to prevent the new onset of allergies in monosensitized patient, as well as progression from allergic rhinitis to asthma. Therefore, immunotherapy should be considered along with pharmacotherapy and allergen avoidance in the management of patients with allergic rhinitis, rhinoconjunctivitis, allergic asthma, and stinging insect hypersensitivity. Which group is eligible? 5 and up is the usual recommendation. But as I said, there can potentially be exceptions. I have kids in my clinic who are doing sublingual immunotherapy at age 4 with us because parents are very keen on getting the therapy going. I'm not going to get into too much into subcutaneous and sublingual. This is not the forum or the purpose of this talk, but there is entire lectures and presentations on this with a lot of data that is out there. In short, subcutaneous is a little better than sublingual for now, maybe between 10 to 30% better, depending on which data and which publication and which author you look at. There are guidelines from the Indian Academy of Pediatrics, the WHO, a lot of other international guidelines, which all say that it is effective, safe, and supported by global guidelines. What are the benefits? I've already gone through this. Absolute contraindication below 2 years. I put a question mark because I told you I personally had one, which was an absolute, which I broke the absolute contraindication. Relative contraindications 2 to 5 years, and immunotherapy can easily be given above 5. I'm just going to briefly talk about other forms of immunotherapy because no talk on curing allergies can be complete without talking about food allergen immunotherapy. Food allergen immunotherapy is still experimental. I personally, because I have experience with oral desensitization to milk, egg, peanuts, and tree nuts, continue to offer it to my patients. But understand that this is something that is not officially approved. You all have probably heard of a product called Palforzia in the US, which has been approved for peanut allergy, but all it does is it increases the threshold at which a child can get a reaction. So the parent will be very scared that if the child even comes in contact with peanut, can have a life-threatening reaction. That child can get exposed to 100 or 200 milligrams of peanut accidentally and still not anaphylaxed. That's the benefit of Palforzia. It does not cure the allergy. Now, do certain patients end up having what is called complete oral tolerance to a food? Absolutely, yes. It has been shown with cow's milk. It's been shown with egg. It's been shown with peanut. But recognize that these are all in research protocols where a lot of reactions occur with these patients. And those reactions are managed by people who are dedicatedly following these patients every week or 2 weeks in their clinic, escalating their doses. The escalation takes about a year to happen sometimes. And after that, the patient has to consume the food on a daily basis for a prolonged period of time if they don't get completely orally tolerized. There is future for even gene therapy. When we look at food allergies, people have tried to make genetically modified peanuts. They've tried to make genetically modified soy. See if you can take away some of the major molecular components. A lot of interesting research, but they haven't been successful yet. They've even tried by giving cats immunotherapy to change the cat's saliva and the amount of allergen excreted in the saliva to see if you can reduce and still have the cat as a pet in the house because the family or the patient won't give it up. So there is a lot of interesting stuff going on there also. With venom immunotherapy, I've just put one slide out there. The effectiveness is above 95%. There is no doubt if it is a truly anaphylactic case that that is the way to go. Why does immunotherapy fail? Wrong setup, wrong patient, wrong allergens, poor quality allergens, wrong dose, and ultimately the wrong duration. I have a lot of these, as I said, companies that are cropping up doing immunotherapy, which say you just have to do it for 6 months. Kindly in your own areas and in your own ways, work to create awareness that these things are inappropriate practice. Nowhere in the world is immunotherapy recommended for less than 3 years, okay? Drawbacks of current immunotherapy: frequent dosing schedules, adverse events, low patient compliance, non-standardized preparations, time and cost. And these are the real dangers of immunotherapy in India, okay? It has taken me the last 11 years of consistently practicing dedicatedly both pediatric and adult allergy in India with a wide group of patients from rural areas to the ultra-rich people to recognize what is going on in all of these patients. But immunotherapy is being based on erroneous blood tests or erroneously interpreted blood tests. The quality of extracts are not what they are supposed to be, and there's a lot of batch-to-batch variation in the extracts. There is a lack of confidence in writing an allergy immunotherapy formula, and hence people rely on companies and organizations to do it for them, which creates a barrier because those people are not seeing the patient or interacting with the patient. There's suboptimal inclusion of relevant local allergens, as Dr. Anand had presented so well. There are so many unique pollens which are not represented on our CRDs or on our immunocaps. And we still have patients who are highly sensitized to them and don't get the immunotherapy because there isn't an extract for it. So there is a lot of work that we have to do with our aerobiologists to work on that. And we are doing work with some groups. Dangers of doing food allergen immunotherapy. I can't tell you how many times I get prescriptions where someone has put a peanut into a mixture of dust mite and cockroach, which is a ridiculous combination. Means if my mentor in America, Dr. Harold Nelson, who's considered the father of allergy in America, would see that prescription, he would fall off his chair. He would say, who is this person and who taught him allergy? Okay. But I see this every now and then, and I see this from a variety of places, because again, there's a big gap between who does the test and who interprets it and who actually prepares the mix. Incorrect dosing and incorrect duration. I mentioned non-allergists prescribing immunotherapy, loss of faith in the physicians and the patients. I had taken over Dr. Nifadkar's practice in talking with his spouse, who was managing his practice for 3 years with me. She said that sir had begun it in the 90s, but had such odd results and unpredictable results with it that he gave it up. So even a physician lost interest, recognizing that the quality of antigens was not great. Poor adherence to the regimens. People are really looking for a quick fix. And so these are some of the issues. Now, coming to a presentation yesterday that you all heard on CRD, And where does CRD take immunotherapy in the future? This is the future, and this is the last discussion that we finished Dr. Marathe's talk on, and where it goes. So with CRD, because we can actually identify the actual molecular antigens that are causing the allergic reactions, and we know which are the major and which are the minor, the future of immunotherapy, besides being able to smartly select, because if you look at this list, it's a very complicated slide. I can't explain it to you completely, but you'll see at the bottom, someone got only GAR, someone got birch and ragweed, someone got grass and ragweed, someone got only ragweed. This is because based on the molecular epitopes that were found on their CRD, based on their clinical history, and based on what their potential skin test allergies might be, very smart decisions were taken to choose only what was required, because mixing more than 3 allergens is not recommended in immunotherapy. And there are people who mix 6, 8, and 10 sometimes together. And then the holy grail is if we can find, okay, we take DERP1, DERP2, DERP3, DERP6, DERP7, and we combine it into one mix and we create an immunotherapy. So now you don't have to do dust mite cultures, because you can recombinantly create the molecular antigens. And you can then give a very specific shot with that. That would be the holy grail. The problem is every allergen has anywhere from 10 to 30 different molecular epitopes that the human immune system reacts to that we know of. There may be more that we have not looked for. And out of them, to know which are the major and which are the minor requires large population studies. And after you do those large population studies, you can have infinite combinations of molecular recombinant that you can make. So there can never be a single product that you can choose. So if immunotherapy now is complicated, if molecular immunotherapy comes in, it may get even more complicated in the future. And so for now, I tell people, go with what you have. The whole allergens have everything that the patient can potentially be skin tested for and desensitized to. And that is the way to go. But this is the future. And eventually, as I said, people are trying different combinations of major determinants to see if immunotherapy can work. So what can we expect ultimately in children? Improved efficacy over symptomatic medications, sustained increasing efficacy, long-term efficacy. And when I say long-term efficacy, I can say freedom from medications, if that comes close enough to cure. Prevention of new sensitizations, prevention of development of asthma, if we can think of it as a secondary prevention, and then reduction of oral steroids, and ultimately cost effectiveness over symptomatic treatment if it is done correctly. All of these are benefits of the immunotherapy. So thank you very much. And if there are any questions, I know they've brought up quite a few controversial topics, but I'll be happy to take them. Otherwise, thank you very much to the organizers, to Dr. Rajkumar and the entire team at Ped Allercon Nagpur and IAP for inviting me for these programs. Thank you.
Thank you, sir. It was a very nice lecture.